Good afternoon, class. My name is Gail Berry. If you don't know, I am your instructor for this medical procedure coding class. And medical procedures, how do you code them? Well, we're going to talk about that here in just a few moments about how you transform these procedures into what is known as medical codes or CPT codes. And so this recording, please forgive me if I pause or sometimes I have to look for certain things, but please, I want you to be patient with me as I go through chapter 13. So with that being said, let's continue on to the next slide, and which is, we're going to go with medical coding. Now, medical coding is where we are going to transform services or procedures or slides or even drugs into what is known as CPT or HCPCS codes, and we'll cover HCPCS more thoroughly in the throughout this at the end of this chapter. But HCPCS is short for Level 2 National Codes, which are the Healthcare Common Procedure Coding System, which is set up by CMS or the Medicare. Medical coding also transform diagnosis and procedures into diagnosis codes. So, levels of service codes. What do we mean by levels of service codes? Well, there's actually 3 levels. And level 1 CPT codes used to identify the services of and procedures delivered by a physician to describe any kind of healthcare service. And then, of course, there's level 2, which are your national codes, which is your HCPCS codes, and those are alphanumeric, and those are going to report services, supplies, and equipment that's not covered with CPT codes. And then, of course, there's level 3, which are codes that actually were phased out in December 31 of 2003. So now we only use level 1 and level 2 codes. Diagnosis codes you are already familiar with because you've already been introduced to ICD-9 and ICD-10. ICD-10, as you know, is going to be implemented in October of this year, and it will replace the ICD-9 CM. You have ICD-10 CM and then PCS. PCS, of course, being for the hospital setting. So we'll move on to the next slide, which is slide number 5, and then we'll proceed on. Why use codes? Well, we use numeric codes and alphanumeric codes when we are completing insurance claim forms because computers understand numbers more than it does verbiage. And so it's going to allow for greater standardization and simplification of the process of interpreting medical diagnostic and treatment information. It makes processing of the claims more efficient, and it permits a compilation of statistics which would be related to your diseases and disorders and treatment protocols. Also, because no information is lost. But not only that, HIPAA. HIPAA, as you know, is the Health Insurance Portability and Accountability Act, and it requires the Secretary of Health and Human Services to adopt national uniform standards for electronic transmission of financial and administrative health information. And so the AMA, who is the developer of the CPT codes, are doing just that by making the code definitions more precise for HIPAA. Now, CPT also known as CPT-4, Current Procedural Terminology, was developed by the AMA, which is the American Medical Association. It was developed in 1966, and because the practice of medicine is ever changing, the CPT manual is going to be ever changing, so therefore it's updated in November of every year, of each year, and then that update is then implemented on January 1. And as I said earlier, it is divided into your Category 1 and 2. Category 3 codes, as we said, eliminated. So what are some different types of CPT codes? Well, we have medical codes, we have surgical codes, we have diagnostic services, we have anesthesia codes for anesthesia that will, when an anesthesiologist puts someone to sleep, he uses a code in that section. Category 2 and 3 codes, those are going to be your alphanumeric, where your Category 2 codes are going to be performance measuring, and we're going to get into that a little bit later. And then, of course, Category 3 is your emerging technology. Emerging technology, now let's don't get Category 3 and Level 3 mixed up. Level 3 again was eliminated for as far as codes, but Category 3 is emerging technology, and so that would be the new technology coming up that maybe a CPT code hasn't been developed for that particular thing because it hasn't been proven that much. So we do have that. But there are 6 main divisions in your Category 1, and that would be evaluation and management, E&M. And the reason E&M is listed first, it's because it's used more often than any of the others. Evaluation and management, that's an office visit, or that's when you go to see your physician, or that's when they're seen in an emergency department, that's when they're seen by someone. So they are evaluated and then managed. Evaluation and management. And it is the very first section of the CPT manual. And the code numbers are going to start with 99, whereas with the next one is your anesthesia. Anesthesia starts with 00. It's number 2, chapter 2. Number 3 would be surgery. Number 4 is radiology. Number 5 is pathology and laboratory, and then 6 is going to be medicine. Now, what does CPT codes allow for? Well, they allow for their numerical codes, and they're used, they're the same for all users, and it just makes coding more standardized and efficient. So they're more effective and efficient. So with this, they are used, as I said, by lots of individuals. And the reason being, consider this: renal endoscopy through nephrostomy or pilotomy, with or without irrigation, instillation, or uropilography, exclusive of radiologic service, with endopilotomy, includes cystoscopy, uteroscopy, dilation of ureter and ureteral pelvic junction, and insertion of endopilotomy stent. That's a lot of words, and it sure would be difficult to explain that on a electronic health form, insurance claim form, or even a CMS 1500, which is the paper version of the electronic 837. So what do we do instead? We use a code, 50575. Isn't that a lot easier and more efficient way to describe this procedure? Sure it is. It sure is. Now, codes are also used to tell third-party payers about services or procedures that are required. So it's going to inform them about the services or procedures that were provided. They become the basis of payment of claims submitted. They are ambiguous and unambiguous way to communicate, and it will expedite the claim processing, so reimbursement to the providers is on a lot more timely basis. So what would incorrect coding do? Of course, it can result in the provider being inappropriately paid, and with that, they're either going to have overpayments, underpayments, or even denial of a claim. And incorrect coding may result in fines, imprisonment, or both, especially if it's the result of fraud and or abuse. And so the financial consequences of this can be detrimental to a practice. And so it's the coder's responsibility. It's the coder's responsibility to ensure that coding is applied accurately and that error-free claims are submitted to third-party payers. Now, who uses codes? Well, they're used by clinics, hospital, rehabilitation units, ambulance services, long-term care, wherever healthcare services are provided. That's where these codes are used. They form the basis for a universal communication system that ensures accuracy and clarity when the procedures and services delivered within the healthcare system are actually described. So, outpatient services for physicians use this. They're reported electronically in billing systems. However, CMS 1500 forms would be your universal paper form. Here, this is a picture of one of the CMS 1500, and the CPT-4 codes are entered in section 24D of this form. The complete information must be provided for each claim submitted, or it will be actually the result of a denial. Effective March 31, 2007, CMS 1500 claim form changed to where it also provided an MPI number. MPI means National Provider Identifier, and that every physician is actually issued an MPI number, and it identifies that physician or identifies that rendering physician or that facility. So when the claim form is sent to the third-party payer, then the MPI is there to identify where it came from. There's also space for 4 modifiers. As you can see, that would be to the right of where the CPT or HCPCS code would go. And the thing with this, the CMS 1500 is used by physicians, practitioners, or suppliers that have fewer than 10 full-time employees. But others, if they have over that many, then they are required to use the electronic version, which is the 837P or just the 837. Now, go forward to slide number, I believe it is 15, CPT format. How is it formatted? Of course, there's symbols in the CPT. And those symbols are used to convey information, actually. And one of the examples that your book gives is the bullseye. And you know what a bullseye looks like. You know, it's a circle with a bullet in it. Well, the bullseye indicates moderate or conscious sedation is included in this code. When it is next to a CPT code, it means that conscious sedation is included in that code, and that you should not bill for the conscious sedation separately. An example of that is 45391, colonoscopy with endoscopic ultrasound examination. Well, as you know, anyone who's going through a colonoscopy, they are sedated. But they're not actually intubated and put all the way out, but they are sedated where they are not feeling any pain. So conscious sedation is included in that code. There's also the lightning bolt, which is showing that a code is pending, and it's usually for medications or vaccines, pending FDA approval. And their example here would be 90650, human papillomavirus HPV vaccine, type 1618 bivalent, 3-dose schedule for intramuscular use. This hasn't been approved by FDA at this point, and so therefore it would have a lightning bolt next to it. You can see all of these. This one, of course, is in Appendix K, and we're going to cover the appendix here pretty soon. Your bullet is actually, you know what a bullet looks like. It refers to a new code, and that would mean that this is a procedure is being included in CPT for the first time. So this code has never been used before until this publication. Then you have your pound symbol, which means it's a resequence code. Some years ago, they started doing this to where the codes would be that if they had a relationship to another code, that maybe they were going to be resequenced and just put in with the codes that they are actually related to. In this case, you have 27049, radical resection of tumor, sarcoma, soft tissue of pelvis and hip area, less than 5 centimeters. Well, what if it's over 5 centimeters? Well, you would use, there's your pound symbol, 27059, 5 centimeters or greater. So see why it has a relationship, so therefore they would use the pound symbol in that. The triangle is used to tell you that this code has been revised, that it has changed in some way, and so the triangle is saying that that it has changed since the last revision or since the last publication. Next are your right and left triangles, beginning and ending of text change. That means that the text within those right and left triangles is saying that has changed. Where here it's saying that pulse generators are placed in a subcutaneous pocket. And then it goes on to say, or beneath the abdominal muscles just below the rib cage. So that was another thing that was changed about it. So it's just telling you that the text has actually changed. It can occur in any section of the CPT, and multiple changes may be noted in a particular section if appropriate, as this example is indicating. Now, next slide. Slide 19, we have an add-on code, which is signified by a plus sign. And this is telling you that with a add-on, the code is prefaced by the plus sign, and that is to indicate that it is an add-on code whose description has been altered in some fashion. In other words, 11,000 debridement of extensive eczematous infected skin up to 10% is going to be coded with 11,000, whereas each additional 10% or part thereof is going to be indicated as 11,001. So that means that that additional code is going to be used in conjunction with the 11,000. You can never use an add-on code by itself. It can only be used with another code. So it can only be used with another specific code. It's never used alone, and no reduction for multiple services. In other words, no reduction means no reduction in the reimbursement for multiple services. There's a full list of in Appendix D of this CPT. And also, add-on codes are Modifier 51 exempt, and we're going to get into Modifier 51 here pretty soon. With a circle with a line, means that modifier 51 cannot be used with these codes. So in your example there, as you can see, there is a circle with a line, and it is 93503, insertion and placement of flow directed catheter. For example, Swan Ganz for monitoring purposes. With that says don't use a modifier 51 exempt code in there. Service is typically exempt from multiple procedure reductions, and we're going to talk about modifier 51, as I said, before long. Your circle is actually a recycled or reinstated code, meaning that it has been used in CPT previously. Now, talking about the appendices. With the appendices of CPT, you have Appendix A, B, C, D, E, F, and G. Appendix A shows your modifiers, and modifiers again is going to actually tell a little bit more about the procedure. There's something else happened along with that procedure. Appendix B, additions, deletions, and revisions of codes. They'll show you the list of codes that have been added, deleted, or revised. Appendix C is going to give you clinical examples. That would be for E&M codes, but that's not to say that you are to use those. Those are just giving you examples to kind of help you to choose the correct code. Appendix D are your add-on codes. Appendix E is your 51 exempt codes. F is 63 exempt codes. And then G, of course, include moderate conscious sedation. Now, others that are included are Appendix H and I. Those H, you would have to actually look on the AMA website in order to get those category 3 codes, or 2 codes, I'm sorry. And Appendix I is also genetic testing modifiers. Those have been deleted for 2013. J are for listing of sensory and motor and mixed nerves. K is again your products pending FDA approval. And that would be indicated with that lightning bolt. Remember the lightning bolt I had told you about? Appendix L is for your vascular families. Those would be, you may be coding cardiology. You will be coding cardiology this summer. And this is for like catheterization procedures where they have to go into an aorta, and that's generally what they go through. And then there's a first order, second order, third order branch. That's where these would actually help you with that coding. Now, Appendix M would be any codes that have been deleted. N is for resequenced, and then your O is your multi-analyte assays. That's more like for oncology. Now, like I said, CPT has actually 6 sections, and they're like chapters. And the first one is evaluation and management. And it is the first one listed because it is the one, as I had told you earlier, is used more frequently than any other. And it begins with the 99201 series. Number 2 is anesthesia. Number 3 is surgery, and this is actually, surgery is the largest one, the largest section in the CPT. Pathology and laboratory medicine, category 2, category 3, then your appendices, and then of course the index would be the last one. CPT is going to be categorized by, as I said, your sections, and sections are would actually be like, you know, E&M, anesthesia, surgery. And then it then is broken down in subsections, which would be the body system. Then it's further divided into subheadings, which would be the brain or the body part or body area. And then it's going to be divided into a category, which would be something like incision, excision, injection, drainage, aspiration, something like that. Then, of course, it's going to have other categorization, and with that would be your anatomy. The anatomy could be categorized by the anatomy of the body, or the procedure, or the condition, description, or even the surgical approach. So it can be categorized by any of these. Now, an example of that would be in your E&M section. The main section is your E&M. And as you can see, one subsection of the E&M is office or other outpatient services. That's a subsection. But then that's going to be subdivided or into what is known as a subheading. And in this case, it is new patient. And so here you see an initial office visit for a 50-year-old male from out of town who needs a prescription refill for a non-steroidal anti-inflammatory drug. Initial means the first visit. And then it would go on to have another subheading where that would be actually showing as establishment. There are guidelines, and these guidelines begin at the first page of each section. So each section has its guidelines, and these guidelines will actually give you or allow you to appropriately interpret and report procedures and services that are included in that section. So before you start coding for that section, you would need to review the surgery guidelines, so you'll be more aware and be able to do a more correct coding. Another thing that's included are notes, and a specific note can be applicable to a group of codes, or it may be just to one code. But notes are another thing that you really need to pay attention to. So it's a must read, and it's located throughout the CPT. There's two types of codes that you need to be aware of. There are your standalone. Your standalone codes have the full description of the procedure, whereas your indented codes are listed under the standalone codes. And it's understood that these descriptions for the indented codes include that portion of the standalone code description, and it precedes the semicolon. So see, that's where the semicolon is going to be very important. And so the purpose of the semicolon is to actually save space. So the words following the semicolon can indicate alternative anatomical sites, alternative procedures, or a description of the extent of that service. But before you can assign an indented code, make sure you refer to the preceding standalone code and read the words that precede the semicolon. That is the only way to ensure a full description and to select the correct code. Okay? So here's your standalone. And then, of course, you had your indented. Your semicolon indicates a full description and preceding code. I apologize for that. But again, please watch the indented code as well. Now let's talk about modifiers. What are modifiers? CPT modifiers. They provide additional information to the third-party payer about services provided to a patient. That's what they do. And so when it comes to modifiers, they are 2 digits, and they are placed after the CPT code to give additional information to the third-party payer. Now, in this is giving you an example of -62, which is 2 surgeons performed a surgical procedure. And what this means is that each surgeon applies their own skill. And so therefore they're going to bill the procedure with the modifier 62. Like with open heart surgery, 2 surgeons are required. You have to have a thoracic surgeon, and then you have a surgeon to do the heart surgery. So the thoracic surgeon is going to open up the chest and then enclose the chest, where the heart surgeon is going to actually do the surgery on the heart. So each of them would bill the procedure using the modifier 62. You also have level 2 HCPCS modifiers. Now these modifiers that are given an example here is -AS, meaning physician's assistant, or -F1, left hand second digit. All modifiers used on CPT or HCPCS must be used in descending numerical order. In other words, if you have a code and you're going to use 2 different modifiers with that one code, then you need to use the descending order, numerical order format, where 62 will come before -50, or 62 will come before 50, because we're going to go in pecking order from the highest to the lowest. Okay? Now, let's look at an example of a modifier. We have 43820, and that would be your gastrostomy, where you have -62, which 2 surgeons were in there performing. So each one had to perform their own expertise. So the modifier 62 is allowed based on the payer. Medicare requires documentation of medical necessity. So if this is a Medicare patient, that means that the doctor is going to have to have the documentation that's going to show that another surgeon was actually needed with that procedure. So let's look. I actually have some exercises for you, and I think this actually came from page 373 in your textbook, and it's exercise 13-6. So let's look at this. What is the 2-digit modifier that indicates 2 primary surgeons? And we've already gone over that. What is it? Sure, it's 62, right? Sure it is. So it's going to be 62. And so if the CPT code is 43820, and I forgot the 20 in there, and 2 primary surgeons perform the service could be stated this way. It would be stated as 43820-62, right? Okay, so now let's go to the next one. A bilateral inguinal herniorrhaphy. And what this is a repair of a inguinal hernia, and it's actually on both sides, so it's bilateral. And the bilateral modifier code is 50. So we know that we would put 50 there for for that one. Now, number 4, a postoperative uterotomy patient has to be returned to the operating room. Unplanned now. This is unplanned because there's a complication related to the initial procedure during the postoperative period. So what would be the code and what modifier would you use? Well, actually, the code, or the modifier in this case is going to be 78 because you had to return to the OR and it was an unplanned surgery. Number 5, a decision to perform surgery is made during an evaluation and management service on the day before or the day of surgery. This would be 57. Number 6, multiple procedures performed during the same surgical session. 51. A surgical team is required. 66. A physician A actively assists physician B during a surgical procedure would be actually 80. So with this, let's advance to the next one. On your CMS 1500, where would you put your modifier? You would actually put it in the slots next to your CPT or HCPCS code. So you'd put your HCPCS code in the first slot and then your modifiers to the right of that. Okay, unlisted services. These are codes that are ending in 99. And that's because no specific category 1 or 3 code is there for them. You only use it if there is not a more specific code that you can find. Use it at the last resort. If at all possible, use a category 3 code. But with these unlisted services or codes, you will have to have a special report. So there's going to have to be a documentation by the physician themselves to help with this, or the claim might actually be denied. Now, let's look at category 1 codes. With your category 1 codes, they go from 00100 all the way to 99607. Again, they have been approved by AMA and also proven clinical effectiveness, or their efficacy. Now, category 2 codes are your supplementary tracking codes. And with that, they are actually used for performance measures. The codes, is use of a category 2 code mandatory? No, it's not, but it is optional, and it's actually used to facilitate data collection. They provide supplemental information, are always used in combination with category 1 or category 3. They are alphanumeric and end in the letter F. And you can find these on the AMA website. Now, category 3 codes, new technology. I told you that was the up and coming technology, emerging technology. They are temporary codes up to 5 years, and they identified the emerging technology or services and procedures. And they're located after the medicine section. They're alphanumeric, and as you can see, end with T. And they may or may not receive their future category 1 code status. So they, as I said, they are not guaranteed to go there. Now, category 3 codes have not been approved and have no proven clinical effectiveness. So use Category 3 codes instead of unlisted codes. Use an unlisted code if no Category 3 code exists. Okay? Now, special or written reports. With your special or written reports, they, as I said, sometimes payers, if you use a non-specific type code, then you're going to have a special or written report. And that special report is going to indicate the nature or extent, the need, the time, the effort, whatever that it was used for that particular procedure. So they must accompany claims when an unusual, new, seldom used, Category 3 or unlisted procedure is performed. Whose responsibility is it to develop the report? It would be the physician. And it helps the third-party payer to determine if the procedure performed was appropriate and medically necessary. So that's when it would be called for. As I said before, the CPT index is located in the back of the CPT manual. It is arranged alphabetically. It has headings located at the top right and left corners, and it's very similar to a dictionary. So it's going to speed up code location. So you have your first entries and your last entries on those pages. Now, with this, as you can see, this is showing you a page. So on the left, the first entry is repair of the iris, where the last entry was repair of the toe. And that would show a repair, you know. So, and the presentation of the codes will actually show single listed codes. These are just one number that's going to identify one thing. It's going to show you multiple codes, and these codes are going to be separated by commas. And then you're going to see ranges of codes that are separated by hyphens. And that's how they're actually formatted. Now, what are some of the methods that you can use to locate the CPT codes? Well, there's 6 different ways on this slide, which is slide number 49. And with that, you have service or procedure. That's one. When using the service or procedure location method, repair would be your main term, and repair of a fracture of a femur, you see. So that's would be your service or procedure. Next is anatomical site, and that would be like the word femur as the main term, and subterms are going to be fracture. Next would be condition or disease. In this instance, you would use the main term, which was fracture in the one I had before, but here cleft lip or clot. And then synonym is the fourth one, and this would be synonyms or words with similar meaning. So a toe joint is actually is a synonym for interphalangeal joint or metatarsophalangeal joint. So there would be a synonym. And then there's an eponym, And eponyms are things that are named after people. So it may be someone who actually discovered this. And so here you have your Jones procedure or Heller operation. And then sixth is, of course, the abbreviation for the procedure itself. Abbreviations are common in medicine for names of drugs and also for diseases and procedures. So any of those would be location methods. Here's another little exercise, and I think this is number 13.9 in your textbook on 380. So with this one, it was actually looking up the main term and then locating the code that would be available for this. And the first one is going to be Emergency Department Services, Physician Direction of Advanced Life Support. So what would be your main term on this one? Actually, it would be emergency. Main term would be emergency. So you're going to look up Emergency Department Services, and then you're going to look up Physician Direction of Advanced Life Support, and that would give you the code 99288. Number 2, condition or disease, intracanteric femoral fracture is a closed treatment. So what's your main term? Fracture. It's going to be your main term. So then you're going to locate, you're going to go to fracture, and then you're going to look up the femur intracanteric closed treatment, and that will give you a code of 27238. Next will be number 3. Procedure is removal of gallbladder calculi by means of an open procedure. Your main term here is going to be gallbladder, and then you're going to go to gallbladder, and then you're going to look up removal calculi, and then of course 47480 is going to be your code on that one. Anatomic site, lung. So you're going to go to lung here, and you're going to look up bullae excision. A bulla is actually an air pocket that's embedded into the lung, and it's caused by either lung cancer or maybe even emphysema. So it's going to be actually excised or taken out or resectioned. So you would then look up bulla lung resection, and it's going to give you the code of 32141. Okay, so let's move on. Always reference your index, and you need to be sure to read all of the notes that apply to the code. And then after you've looked in the index, then you will locate the code in the main portion of your CPT. Again, as I say, read the entire description and any notes that may apply so that you can have the correct code selection. Okay, let's go on to the word C. C is a cross-reference term. It's found in the index of the CPT manual, and what it's telling you is directing you to another term or other terms so that you can find your code elsewhere. Okay, so here it's your index have stem, brain. It might say brainstem. Go to brainstem and see if you can find what you're looking for there. Let's talk about HCPCS. HCPCS, again, are your codes that were created by CMS, Healthcare Common Procedure Coding System, and they were developed by the Center for Medicare and Medicaid Services, who are known as CMS, who was formerly known as HCFA. And this is really a two-part coding system, and what is included is codes that represent procedures, supplies, products, services that may be provided to Medicare and Medicaid recipients. And so now some of your private healthcare companies are also using HCPCS also. They were developed in 1983. What happened was CPT didn't contain all the codes necessary for these, and so that's why CMS went ahead and created another manual. And they do have different levels of codes. Level 1, again, is your CPT. Level 2 is your HCPCS, also known as national codes. And then level 3, we had already determined had been phased out and is no longer used. Some of them were integrated actually into your HCPCS codes. Okay, let's continue talking about level 3 local codes. Again, they were discontinued, so I don't see any need of going any further with these. Level 2 codes are your HCPCS codes. They are used by physicians, dentists, orthodontists, and also temporary codes for your Medicare. They are also used for ambulance services as well, which are not covered by the CPT. And just remember that level 2 HCPCS codes are also known as national codes as well. With these codes, they are codes for a great deal of different services, also for specific drugs and for durable medical equipment, and as I had said before, ambulance services as well. They have gained popularity not only by they're used, of course, by Medicare, but now many of your third-party payers are now requiring the use of HCPCS codes when you are filing your insurance claims with them. Each year, the numbers of HCPCS codes actually increases. And the third-party payers are actually beginning to use these a lot more because it does allow for continuity and specificity, or more specific codes for that. Now, what is the format used for the HCPCS codes? They begin with letters, and then it's followed by 4 digits. Okay? And one of your examples of that would be your E0618, which is apnea monitor. And then, of course, each letter is going to represent a group of codes. For example, your J codes are going to be used to report drugs and dosages, so you would always know that a J code would be used. Now, the first digit I said is a national code, is a letter, and it can go anywhere from A all the way to V, and each one of them is going to have a meaning of some sort. Temporary codes would be some of the letters like G, K, Q, S, H, T. Those are all temporary codes. Example would be a K0006 heavy duty wheelchair. So maybe it's going to just be used temporarily. Code books are published every January, but codes are going to be added, deleted, or even revised throughout the year. And so you would be notified through the carrier bulletins. Carrier meaning the insurance carrier would actually give you those updates. Now the thing, remember that there are some things that just aren't covered with insurance, and just because it has a HCPCS code does not mean that it's going to be covered. And one of the examples of that is the V5130 binaural hearing aid is not covered under Medicare, so therefore the recipient would have to pay that out of pocket. So they're going to be used in different in outpatient settings, and that would be also outpatient departments in hospitals. They are not used in the inpatient arena. The HCPCS index, which is at the beginning of the manual, and you each should have one because you are going to need to use it to look up HCPCS codes. You don't want to, again, code directly from the index. You're going to use the index and then go on into the body of the coding manual. Your reference main portion text before assigning the actual code. And the main index terms are going to be include tests, services, supplies, orthesis, medical equipment, drugs, therapies. Those would be some of your main terms that are actually used. Here's an example. It's figure 13.22, and as you can see, they are in alphabetical order, and they are in red in your HCPCS manual. Now, another thing, they're showing you the J codes for your injection, and there's rules that you need to abide by in order to locate the code in the main part of the manual. So you never code directly from the index. You always use both the alphanumeric listing and the index. Analyze the statement or description provided that designates the item that requires a code. Identify the main term in the index. Check for relevant subterms under the main term, and verify the meaning of any unfamiliar abbreviations. Note the codes or code that found after the selected main term or subterms. You want to, after locating the term and the code in the index, verify the code in the tabular to ensure the specificity of the code. In most cases, for each entry, a specific code is provided. In some cases, you are referred to a range of codes, among which you can locate the required one. You must review the entire range of codes in the tabular to locate the correct code. In all cases, when locating an entry in the index, it is necessary to look at all descriptors under the main term and subterms in order to identify the correct entry and to locate the code in your tabular. Now, modifiers. There are modifiers in your HCPCS, just as they are in your CPT. There are more than 50 alphabetical modifiers available for assignment, and that would be, of course, to add further specificity to the 5-digit national code. They can be used to specify the service provider or specify the anatomical site or even add the specificity. So what we're going to look at here, as you can see, AK is non-participating physician. Also, you have physician team member service, AM. E1 is upper left eyelid. E2, E3. Then you have LL, NU, PL. So these are all modifiers. So your CPT and HCPCS modifiers are used with both HCPCS and CPT codes. Now, and modifiers can be found, of course, in the indexes of the coding manuals. And there is a difference in CPT and also HCPCS modifiers. Anatomical modifiers, as you can see, are going to identify the anatomical site, and you would need to use them, as you can see here. And then often used are your modifiers to indicate the left, the right, and they would be LT or RT. So example would be right kidney biopsy, 5200 RT. Left kidney biopsy would be a 5200 LT. And then of course you have your ambulance modifiers, and these will actually tell you the origin of the care and the destination, and they're used in combination. So the first letter is going to actually give you the origin, where the care started, and then second letter is going to tell you where it ended up, or its destination. Your example here, R is resident, H is hospital, so RH, origin, first letter, residence, destination, second letter. So those would be used for modifiers. Here is a listing of a table of drugs. This is something else that is used as you know in the HCPCS, and J codes are used to identify the drugs administered and the dosages that are given. And they're given in generic names. So how can you know, or how do you find the brand name of a generic name? Well, you just look into a drug reference book, the physician's drug reference book, or some other type of drug reference book. And as you can see, the route of administration is also given there. So let's say diazepam, which is the first one listed, up to 5 milligrams. Here is a listing of a table of drugs. This is something else that is used as you know in the HCPCS, and J codes are used to identify the drugs administered and the dosages that are given. And they're given in generic names. So how can you know, or how do you find the brand name of a generic name? Well, you just look into a drug reference book, the physician's drug reference book, or some other type of drug reference book. And as you can see, the route of administration is also given there. So let's say diazepam, which is the first one listed, up to 5 milligrams, given IM or IV. You have a J code of J3360. Digoxin, that again, these are generic drug names, up to 0.5 milligrams, IM, IV, J1160 would be the HCPCS code for that one. Now, DME, durable medical equipment. Now, durable medical equipment is equipment used by a patient with chronic disabling condition. But not only that, but it can also be used by some patients who are in rehabilitation. And this would be patients who may have had hip surgery or something like that. So Medicare and Medicaid pay for some of the DME items that are used, but a physician must actually give a certificate of medical necessity before Medicare or Medicaid actually reimburse or pay for the DME. And also on home oxygen therapy, Medicare may also pay for oxygen with certain medical conditions. And then again, the physician is going to have to complete a CMS 484 attesting to the medical necessity on that. Each fall, the Centers for Medicare and Medicaid Services produces what is known as the National Physician's Fee Schedule, and it's going to list all the HCPCS and CPT codes along with the amounts allocated for each service. So a list of these fees are there for the practice to use. And also a list of fees for drugs is produced on a quarterly basis, and that's going to be based on the average sale price. And that concludes this presentation. I certainly hope that it has given you a little bit better insight on what CPT coding is all about, procedural coding. And so if you have any questions, please don't hesitate to send me a message, and I'll get back to you as soon as I can. So thank you very much.